Several studies have been looked at over time to try and determine what is the value of PSA screening, and should we continue to screen for PSA and screen for prostate cancer. And probably two of the largest studies over the last decade have been both an American study, the PLCO trial, and a European counterpart study, the ER-SPC trial. And the trial on the left, the PLCO, which is the American counterpart to these screening programs, found that there was really no difference in overall survival between those individuals that were screened and those individuals that were unscreened. The European trial, however, did find a difference at long-term follow-up, that there was a significant reduction in mortality in those individuals that were screened for prostate cancer. The U.S. Preventative Task Force, which makes recommendations on healthcare decisions, they came out with a recommendation and a conclusion to say that PSA-based screening results in small or no reduction in prostate-specific mortality. As a result, they gave PSA screening a grade D recommendation, which indicates that we should not be screening for prostate cancer. And as a result of those recommendations, PSA testing has gone down dramatically. We also see that prostate cancer diagnosis has gone down as well. But very interestingly, we see that in the white bars, high-grade prostate cancer, the kind that's less curable, has gone up. So in 2017, the U.S. Preventative Task Force changed their decisions to a grade C, that it really should become a shared decision-making process for PSA screening in men between the ages of 55 and 70, but against PSA screening in men over 70.
We've become much more restrained in recent years in going forward with prostate biopsies, understanding a little better the risks associated with that procedure and the concerns for overdiagnosis of slow-growing cancer. So there are a couple things that we do in the clinic when a man comes in with an elevated PSA. The first is to have a discussion about what's been going on with that man in terms of his urinary symptoms and overall health. There can be inflammatory fluctuations. The patient could have had a recent catheter placement or a recent urinary tract infection. So it's important not to be overzealous in rushing to stick a needle in a prostate, because you can really tease out some important details just with a conversation. Perhaps most importantly now, based on some very compelling new evidence, we're using MRI in men prior to an initial prostate biopsy to assess the prostate. It's typically pretty straightforward, and one can get a non-invasive assessment that's fairly accurate.
How can you keep genomics simple? Imagine you're building an apartment building, okay? So the architect comes along and they have an instruction manual for your apartment building. And the way the apartment building gets built is that every time that you get a new apartment in the building, somebody sits there and types out this whole instruction manual by hand all over again. And that's what we have right over here. Your DNA is basically that 3 billion letter instruction manual that every cell in our body has, okay? Then you have the RNA. Now, if the workers kept going back to that manual every time, they'd all be bumping into each other. So what you have, essentially, the workers copy what they need just to make their part of the apartment. That's the RNA. And then what happens is what actually the output of the RNA, that's the protein. Over time, that poor guy that's typing this 3 billion letter instruction manual over and over again, so they're not such good typists. Every now and then, a few errors start getting into it. Somebody has got to be the building inspector. The most simple thing that you can do is you can go to the first floor and you can look at that very first copy. Are there any errors in that initial blueprint? And that's basically what you're doing, is you're looking at the DNA that's present in every cell in the body. That's what we're all born with. So the other thing you can do is you can say, well, I'm just going to make sure that the kitchen cabinets are well made. That's like assessing the RNA. And so when we talk about a lot of these genomic tests, what we're talking about is looking at the RNA, sort of looking at the working copy of what's going on. The other thing you can do is you can, of course, look at the proteins and sort of figure out what the output is. It's often not as easy to do. At any point, you can take a sample of tumor and you can really do an assessment of, again, all three of these things and use it to make a bunch of different decisions depending on sort of where somebody is in the point of treatment or diagnosis.